Good afternoon, and thanks for joining us for today's Healthline 3. I'm your hostess, Courtney Butts, and Healthline is where we like to focus on ways to live a healthier, happier, and pain-free life. We'll be taking your calls and answering your questions live in the studio today. We'll be opening those phone lines soon, but as a reminder, please make sure you're in a quiet room when you call, with your TV turned all the way down so that we can hear your question. That number to call will be on your screen. It is 318-219-4569. And today we're talking all about diagnosis and treatment of gallbladder disease and gallstones. Joining me today to talk about this is Dr. Kishore Malireddy with WK Advanced Laparoscopic and Robotic Surgery South. Thanks for joining us.
Thank you, Courtney. Appreciate it.
Yeah, so this is something that's pretty common.
Oh yeah,
gallbladder stones.
Gallbladder disease is a common disease. We see common surgical problem. About 10% of the population have gallstones, and typically they come by with symptoms of abdominal pain, nausea, vomiting as soon as they eat some fried food or like a greasy food. Mostly pain is in the upper abdomen, sometimes radiates to the back, and yeah, it's a common symptom. They come to the ER sometimes with these gallstones, and yeah.
Okay, and so, but abdominal pain is a pretty common symptom for many different things. So
That's
how do you know it's the gallbladder that's causing that?
That's right. So the common symptoms, like yes, there could be other sources for abdominal pain, like acid reflux is one of the common thing, can cause problems, or could be sometimes with a peptic ulcer disease, like people have like bad gastric ulcer or duodenal ulcer causing this abdominal pain, or sometimes people have what you call as a pancreatitis, inflammation, bruising in the pancreas causing the problem too. So, but again, we just put everything in, like, you know, a perspective. Like for example, doc, I had a nice fried food yesterday, like hamburger, pizza, or something like that, and then or something greasy, and then they come by next day to the ER with abdominal pain. Like that's a typical goes in, and then nausea, vomiting, pain radiating. Yeah, that's typical story about the gallbladder. Yeah.
Yeah, and that's, you know, I'm sure a lot of people get an upset stomach with high-fat foods, but it's the severe pain that you're looking for.
Yes, and the severe pain, and also that there's a pattern for the pain to kind of radiates to the back, and also like upper abdomen as well, and they feel bloated all the time, and yeah, and then that's when most of people say, like, I've been staying away from fried food, still I have symptoms. Then that's like bad, really getting worse, and then we just need to get it out. Yeah.
So is this something that you think happens over time? Like, is this this pain that builds up, or is it seemingly random?
No, it's basically how it works is it's kind of interesting. These gallstones, how it's like not like sometimes people are tell me like, Doc, I didn't eat any rocks. How did my gallstone fill up with rocks?
Right.
So it's basically the gallstones or like pebble like pieces of digestive fluid, and it just clumps up and forms like a small stone, like small pebbles. They clump up to form the larger stones. They're basically cholesterol and bilirubin stones kind of forming them. Yeah.
Okay, yeah, so I think it's important to first, before we talk about how we actually what causes gallstones, is, you know, what does the gallbladder do in the body?
Gallbladder is a pear-shaped organ. Actually, it's a digestive, one of the system parts of the digestive system. It actually sits right here on the right side of the abdomen, and it basically, the liver produces what you call as a bile. It kind of is a storage organ for the bile. The bile sits in the gallbladder, and then we need bile to digest all the fatty foods and all that. So when you, for example, when you eat like a pizza or some French fries or something, we need that bile to digest the food. So the gallbladder, typically they squeeze to empty the bile into the GI system, and that's the normal function of the gallbladder. And basically we have this emptying, and then they digest with they mix up with all the fatty foods, and then that's when they kind of absorb all the fats. Yeah.
Gotcha. Yeah, I love this, like a little anatomy session.
Yeah, just got it. I thought like it would be more useful show and tell then.
Right. Yeah. Okay. And so what happens when, you know, there's maybe dysfunction with the gallbladder?
So yeah, so there are like different types. As I'm glad you brought up that biliary dysfunction, because sometimes people walk in with like abdominal pain, everything sounds like a gallstone problem, but still they will not have any stones in the gallbladder. Normally when there are stones, they kind of block the outlet of it, and that's when we know that is the problem. But sometimes they don't have, they have a good function. I mean, they're not functioning well, meaning the gallbladder is filled up with bile. When you eat the fried food, it's not emptying well. That's when you feel that pain, like really discomfort on the below the rib cage on the right side, and bloating. That's when we do a test called a HIDA scan to check the function of the gallbladder.
Okay, gotcha.
Yep.
And then, so from there, what then causes the gallstones?
So gallstones, as I said, typically they just form up by clumping up all these gallbladder with the bilirubin and the cholesterol. They kind of sometimes, mostly cholesterol gallstones.
Okay.
And they block the outlet of it, and that's when you have the symptoms of that cholecystitis and all that. Yeah.
So there's a lot of inflammation going on.
Oh yeah, there is a lot of inflammation. Like for example, gallstones can present in multiple ways, causing problems. Like for example, they block the outlet of the gallbladder. Like actually I have a nice model showing it what's going on up here. So this, for example, this is the gallbladder with the gallstones, and if it blocks the outlet of it, that's called acute cholecystitis. People will have, this is not able to empty, constant really dragging pain, and they can't even take a deep breath. And they come to, that's called acute cholecystitis, one of the emergencies. We need to take the gallbladder out.
Okay.
And these gallstones can cause multiple issues, like not only causing acute cholecystitis, some of them kind of sneak in out of that exit into the biliary system. They block the whole channel, and the bile cannot empty into the GI system. Now it's backed up into the blood. That's when we got as jaundice, and people really get really sick, and cholangitis we call it as. And then that's when the GI doctor goes in through the mouth, and then they, through the stomach, and then they clean out the duct, and then we take the gallbladder out.
Okay. And so you said the acute phase is when it's an emergency.
Emergency, yes. Yeah. Okay. And then one more thing, it's called chronic cholecystitis, is when what happens is these stones, they block the outlet of the gallbladder, they fall back. That's called biliary colic, or the patients go to the ER with abdominal pain, and then we do an ultrasound. Yes, there is stone in the gallbladder, but they fall back and the pain goes away, and then the patients go home, and they tell them typically, okay, you have chronic cholecystitis, go see a general surgeon to take it out. That's the common scenario actually. So I see patients electively in the office with a recurrent what you call as a biliary colic or a chronic cholecystitis, and then we go in and take the gallbladder out.
Okay, gotcha. And so is there ever a situation where you would take out the stones and keep the gallbladder?
It's very, very unlikely. We don't normally recommend it because, again, this is prone for stones, and it just happens again. So normally we don't recommend taking the gallstones out, because it's not like the kidney stones, we just, take them out. But this is where we can take the whole sack of stones with the gallbladder out. We just take it out.
Okay, and so, some people at home might be thinking, well, I don't want to have gallstones, or I don't want to have cholecystectomy. So what are maybe some of those risk factors for gallbladder stone formation?
So typically, gallbladder disease is more like a disease of people with obesity or overweight, and so there are some certain factors called metabolic syndrome, like people with diabetes, high cholesterol level, generalized increased body fat. They are more prone for gallstones. And then there are patients with, typically more in a female population, this is more prone because of the hormonal changes, pregnancy, and then oral contraceptive pills, hormone replacement therapy. They increase the chances of this gallstone formation in these patients. And otherwise, most of the times there is certain disease like a hemolytic anemias, for example. Sickle cell disease patients have more prone for gallstones, and typically their stones are called pigment stones. Bilirubin is more in those stones. Normal stones are typically cholesterol stones. They're common in this obesity and all that. But hemolytic anemias have a different pattern stones. They're called pigment stones, and it's mostly bilirubin based stones.
Gotcha. Okay, we have our first caller. I'll let you get your earpiece in so that you can hear her question. Mary, thank you for joining us, and I'll give him just a second so he can hear you. Okay, Mary, thanks for joining us. And what is your question for Dr. Malireddy?
If you do have your gallbladder taken out, I know there are benefits for the gallbladder for your body, but if you have it taken out, aren't you taking away the functions that the gallbladder helps with your body?
Yeah, Miss Mary, that's a good question actually. So typically the gallbladder, as I said, its function is to store the bile and release the bile when we need it for GI system to digest all the fatty foods. But the body is amazing. Like once we take the gallbladder out, the what you call as a bile duct kind of slightly gets increased in size, acts as a like a replacement for the gallbladder. So, if, for example, if you do a scan on a patient who had a gallbladder like 5 or 6 years ago, we do the ultrasound on them. Now the bile duct is slightly increased in size to compensate for that loss of the gallbladder. So that's kind of a interesting fact. But most of the people they do fine with after the gallbladder out. But I should tell you this: once we take the gallbladder out, I typically tell everyone there is always a risk of diarrhea. Initially on, because the body is not used to all the bile dumping into the GI system, they do have symptoms of diarrhea. But again, it's most of the times it's well controlled. The body gets used to it and kind of slows down the GI system, or people will find out, okay, this food is causing me diarrhea, let me stay away from it, and that usually fix it. And there are some medicines as well to fix it as well.
Okay, because I've had gallstones for several years. Haven't done the gallbladder surgery because of the fact that I know there's benefits that may be taken away from me if I have it out. So I'm hesitant as far as getting diarrhea, constant diarrhea or whatever else I could get.
No, totally agree with you. And then I tell everyone too, not all the people with gallstones need to have the gallbladder out. We got to see if you're having symptoms of it or not. For example, if you're having symptoms like, that one I talked about, abdominal pain, nausea, vomiting, bloating, definitely I would recommend, because you don't want to end up in the ER with an acute situation with that problems we talked about. Oh, one thing I did forgot to mention is called a biliary pancreatitis. The smaller stones can pass through the pancreatic duct and cause really inflammation of the pancreas. They can get really sick from it. So that's one thing we don't want you to go through if you have symptoms from the gallbladder.
Okay. All right. Thank you very much.
All right, Ms.
Thank you, Mary, for joining us. And if you're just joining us and you have a question for Dr. Malireddy, you can give us a call at 318-219-4569. We'd love to hear from you and hear your questions, especially if you may be struggling with this, personally. I think that she brings up a good point of deciding whether or not to have that surgery. So what would you suggest, maybe someone that knows that they have gallstones, do they need to have a referral to be sent to you?
Totally.
Have that conversation?
Yeah. So typically most of the ultrasound and all these images are done by the imaging done by the primary care doctors. Once they know they have the symptoms, they'll do the ultrasound. Once they confirm, or even a HIDA scan to check for the function. And then once they know the problem, send to the general surgeon referral. And then there are certain steps we go through, make sure the patient is ready for surgery, like, make sure cardiology standpoint, the patient is fit for undergoing general anesthesia, and then schedule the surgery and take it out. It's a day procedure, so they come in the morning, get it done, go home same day. That's a good part of it. Most of the time they go home, rarely with some major medical problems or someone who needs a close monitoring. We might keep overnight and let them go home next day.
Okay. Yeah, and Mary also brought up a good point about, knowing what the gallbladder does. We talked about how amazing it is and how it helps digest food, but we can live without it. And there are many people that are successfully, are able to digest food and things, but maybe at first, like the diarrhea, do you feel like people need to change their diet a little bit, maybe lower fat for a little while?
Totally. So main thing, like for example, when we identify a patient has stones and then they're totally asymptomatic, I'm sorry about this.
That's okay.
Totally asymptomatic, and we typically recommend them to exercise, lose weight, and watch what you're eating, calorie control, and watch out the fatty foods. Try to cut down on the fatty foods, losing weight. And then there is one more thing called rapid weight loss can also precipitate the gallstone formation as well. So you don't want to lose really rapidly as well. Like sometimes we see people with bariatric surgery, like after weight loss surgery, they start developing gallstones. So that's one thing is there. You don't want to lose rapid weight loss, but yes, watching what you're eating and
Sustainable
Sustainable
approach.
approach.
Yeah.
That's right. Yeah.
Uh-huh.
Yeah. Yeah.
I love that. I love that that's that there's the research there to prove it too. So so one thing that you do is also, you've probably seen in several years advancements in your practice with robotic surgery.
Oh, yeah.
So tell me about that and how it's improved patient outcomes.
Totally. Robotic approach is, I would say, standard of care nowadays. But still, people are still using laparoscopic gallbladder surgery. Like multiple surgeries have been done laparoscopically, but still, the advantage of robotic, I feel like, lesser post-operative pain, the recovery is faster, and the scarring is less. And then coming from the surgeon standpoint, actually we have a better precision and control of the the robotic arms, and then we can do on the 3D view camera too is impressive, and then we can do more complex procedures safely through this robotic approach actually.
Okay.
Yeah.
And where are these incision sites?
Oh, incision sites are mostly like you'll have like 3 or 4, total 4 cuts in the upper abdomen, mostly, around basically in the line with the belly button, total 4 cuts, and then it's a smaller cuts, and then we'll do absorbable sutures on there, small scars up there. Yeah,
Okay.
it's very impressive compared to like old days where we used to do big open gallbladder surgery, big cut under the rib cage, and now compared to that, it's way easier.
Right, okay, and the recovery, so they go home the same day most of the time, and then when are they back doing their normal activities?
Yeah, so typically I tell my patients, like, in a week you're back to normal, unless like there are people who does like heavy lifting, strenuous activities. I tell them no heavy lifting for about, no heavy lifting more than 10 pounds for 3 to 4 weeks, but they can go back on a light duty or something like that within a week, yeah.
Okay.
Yeah, I see them like post-op in about a week to 10 days and then released to go back to work. Yeah.
Okay. So I have just out of curiosity, maybe what are the biggest gallstones that you've seen and taken out or removed?
Well, one of the gallstones I removed, that's probably actually presented in one of the bigger surgery meetings. The largest stone I removed was 5.5 centimeters.
Okay.
Recommendations anything more than 5 previously used to be like go for a open approach, but I was able to safely remove it laparoscopically, a 5.5 centimeter gallstone, and actually presented at one of the meetings. Yeah.
Okay, very interesting.
Yeah, interesting. Yeah.
And so, what is the difference between like what makes a gallstone versus a kidney stone? I don't know if there's any differences there.
Yeah, definitely. That's a good question, because there is more calcium in the kidney stones. That's when, for example, when you do a simple x-ray on a patient and they might say, oh, you have a kidney stones. They say like, oh, because of the calcium concentration is more and can pick up right away on the x-ray. Whereas these stones are a little more cholesterol stones. The gallstones are more cholesterol and less calcium in there. So it's not picked up by the x-ray. And there is one thing called a porcelain gallbladder where calcium really deposits in the wall of the gallbladder, and sometimes on x-ray, that's like long-standing calcium stone, gallstones, that when we can pick up on that x-rays. Yeah.
Okay, very interesting. And so, is robotic surgery like the only option as of right now, or are there other options?
No, actually, robotic surgery, yes, it is advances in surgery, but laparoscopic gallbladder surgery is like more commonly performed, if you ask me. But but again, the robotic surgery is on the rise, and more people are more surgeons are adapting to do it. And and laparoscopic, and then other surgeries open, the good old open surgery. For example, if there is a really bad inflammation or difficult anatomy to understand, or big cancer in there too. Sometimes gallbladder has cancers too, so sometimes we do that.
Yeah, is there ever an instance where if you don't remove the gallbladder that it can develop any, other issues?
Yes, definitely, as we said, the gallstones we talked about causing acute cholecystitis or cholangitis, meaning blocking up of the bile duct, or can cause pancreatitis. I wouldn't scare anyone with develop a cancer, but like it's rare to have a gallbladder cancer. Like, for example, if you take 100,000 population, like 1 to 2 patients who have gallbladder cancer. It's not that common, but the risk factor, for example, if you have larger stones, more than 2 centimeter stones, and if you have a long-standing stones, like for example, more than 20 years, generally they say there are certain other risk factors like what you call as a choledochal cyst and some other increased risk factors for gallbladder cancer. but commonly it's not. And then most of the times we find out the cancer incidentally after I take the gallbladder, send it to the pathology doc, and then they'll call me like, hey, I found a cancer in the gallbladder. So again, most of them are early stage gallbladder cancers.
Okay, interesting. So non-surgical options for treating gallstones. We mentioned a lot of the lifestyle changes. Any other treatment options?
There are. I mean, I wouldn't say typical. I wouldn't typically advertise for that, because there are some certain studies they have done, and they found out like this thing called Actigol. It's a bile acid. They just take it and they digest that. They kind of dissolve the stone, but again, the outcomes are not great with that. Once they stop taking the medicine, it comes back. The stones comes back. So, and then we did talk about briefly about the kidney stone. Like that, they do what you call as a lithotripsy on it, but still they come back with that. So it's not recommended. Ideally, once they start having symptoms, I recommend taking it out.
Right. Okay. And this is purely out of curiosity. And do you ever recommend digestive enzymes?
Not much for these. Pancreatitis, chronic pancreatitis, people take digestive enzymes because pancreas is not able to and then supplement with some enzymes, but not for these. These typically, once you start having symptoms, best is to go ahead and start taking it out, because you don't want to have an acute episode while you're on a cruise in the middle of the ocean. That's all I can tell for sure.
Yeah, and when you're probably eating high-fat food.
High-fat food, and then that's exactly it.
Okay, yeah, and it's one thing that you can't really remove your pancreas. You can't really live without something like that.
That's right.
But you can with the gallbladder.
With the gallbladder. And then the reason why I stress the importance is kind of interesting. The stones, the larger stones can cause cholecystitis because they cannot escape the bile duct. They cannot escape into the bile duct. They get sit. It's like a bottleneck, basically. The stones cannot escape, larger ones. The small stones can cause pancreatitis. It pass through the gallbladder, out of the gallbladder, and cause pancreatitis. So the small ones are the ones which cause trouble with pancreatitis. Large ones, acute cholecystitis. Yeah.
Gotcha. Very interesting. Learning lots of stuff today. That's good. Okay, so maybe somebody is nervous about having gallbladder surgery. Is it a risky procedure?
It's not really a risky procedure. I mean, compared to general surgery procedures, I would say less riskier procedure, and the incidence of bleeding is less than, like, even the reported incidence is less than 0.6, 0.6, less than 1%, most of the complications. Again, as I said, it's mostly laparoscopic in and out procedure, so the chances of having major issues like clots in the legs or pneumonia, again, is very less, because we push them to we try to encourage them to ambulate and, take deep breaths, so its chances are so low risk with that.
Okay.
And with the robotic too, actually, we have better imaging, and then the surrounding structures, we identify everything, and then the outcomes are better.
Okay. Yeah. Well, that hopefully will put some people at ease, knowing that it's a pretty common procedure.
Yes.
Right. And so it's pretty common. You're able, if there are issues, you will keep them that night.
That night, and then
them.
let them go next night. And sometimes, rarely, with what you call as acute cholecystitis, there's a lot of inflammation, edema, and swelling. We leave it drain in there to suction out all the fluid, and then in a day or so we'll take it out. Yeah.
Gotcha.
Yeah.
So when there is an emergency surgery, that's you're kind of being rushed to surgery, but you can actually schedule this surgery as well.
Totally, yeah. Emergency surgeries through the ER, but elective procedures, they keep having the recurrent episodes, and then we'll set them up for the procedure, like pick a date. Pick a date for the procedure and take it. Yeah.
We have another caller on the line.
Sure. Yeah.
Anita, thanks for joining us, and what's your question?
If I want to find out from the doctor if you have had previous surgery on your gallbladder, and you also have already issues with your insufficient enzymes considered with your pancreas. Can that have any affiliated with the two?
So you had a previous gallbladder surgery, and then what else with the pancreas?
If you have an insufficient enzyme sufficient.
I think, so you're asking if you've had the gallbladder surgery before, so you've had the gallbladder removed, and then additionally needed the digestive enzymes as a result of pancreatitis?
No, you had the enzyme insufficient situation where you're taking creon for the enzyme, for your pancreas. Due to you not having the necessary enzymes to break your food down.
Gotcha.
And you end up having to have surgery for your gallbladder after the fact. Could those two be affiliated from one to the other?
Very unlikely, Ms. Anita. Basically, this gallbladder as such, it's not really linked with, it is linked with the pancreas, but again, the function of it, because the gallbladder is mainly storing the bile and the pancreas is secreting the enzymes, so it shouldn't be causing that pancreatitis and need for creon and all that. Yeah. It's mostly from the chronic pancreatitis, I assume.
That you would need those enzymes.
The enzymes, yeah.
So they're kind of separate.
Separate,
so pancreatitis, you would probably need some of those digestive enzymes or maybe dysfunction of your pancreas. With the gallbladder, not so much.
Not so, yeah.
Did that answer your question?
Thank you.
Thank you.
All right.
Thanks for joining us, and we just have a couple more minutes. And so Timmy, let's say someone is preparing for surgery. They have one coming up. What can they do to prepare for that surgery?
Main thing is obviously when they're, for example, once we schedule the surgery, we kind of give clear pre-op instructions like nothing to eat after midnight, and then if they're on blood thinners, hold the blood thinners depending on what medicine they're taking the day before, or like for a few days or 5 days, or depending on what medicine they're on. And then we ask them to take a shower with a medicine called, it's a medicated soap called Hibiclin to reduce the risk of wound infection. And then the other other things we kind of tell them is not to shave, because there have studies shown that shaving will increase the risk of wound infection. So we kind of do a clipper on the day of procedure. So just that's one thing I always tell them, make sure, because people think like, let me help the doctor, let me clean, shave. So that increases the risk of wound infection. So, and then on the day of surgery they come by, they'll be asleep, they'll not feel any pain or discomfort, and then make small cuts, put the lighted camera in, and take the gallbladder out.
All right, yeah, so pretty in and out, quick procedure. And so how often do they follow up with you after?
Oh, it's typically like post-op, like about a week or 10 days, and then make sure they're doing fine, and go home after that. Yeah. As I said, I don't see commonly people with post gallbladder surgery diarrhea, but I'm sure my gastroenterology colleagues might be managing that with the diarrhea. But again, it's not, as I said, it's not that common, but I do encounter sometimes that situation.
Yeah, so diarrhea is the main symptom.
That's why I kind of warn them about, but there are some people with chronic diarrhea come by, so I tell them there is a problem, it can happen, you can have chronic diarrhea after that. And then one more thing, I do tell patients is one thing is called a post-cholecystectomy syndrome. People, once we take the gallbladder out, and there were gallstones, we took it out, but still some patients have chronic discomfort in there. So that's rare, though it's not that common. If not, we wouldn't be doing this many gallbladders.
Yeah,
it's rare, but I kind of tell them all, just kind of prepare them what to expect. But most of the times they do great, and they'll be very appreciative. Now I'm able to eat food and without problems.
Not have any issues. Right. Okay. And so what happens, or what happens if someone decides not to have this procedure? We've kind of mentioned it before, but kind of that point home.
Most of the times if they don't want surgery, they will end up, most of the times, if they're starting having symptoms, they'll end up with these problems, like all these we mentioned earlier. But again, I try to, from the surgeon standpoint as well, we prefer to do it more electively than an emergency procedure. The risks and complications goes higher up when we do it. For example, the bleeding risk is more, injury to surrounding structures is more, risk of pneumonia is more. Everything kind of doubles up when we do an emergency situation. You don't want to wait till that long and just take it out before the symptoms start.
Exactly. Take it out.
Take it out before it gets worse, and more elective procedure.
Well, if someone at home knows they have gallstones, or if they want to get in touch with you, where are you located, and how can they get referred to you?
I'm located at the Willis Net South, and it's in the Suite 401, and that's it.
And your number is right there.
Number is right there. Yeah.
So take that down.
5758. Yep.
That's pretty easy to remember. 212-5758.
That's right.
All right. Thanks, Dr. Malireddy, for joining us.
I really appreciate it.
And if you missed this will be on our website at ktbs.com/healthline, and the number 3. It will also be located on anywhere you get your podcast. This will be posted as a podcast as well.
Awesome.
All
Thank
right.
you. Appreciate it.
Thanks for joining us and have a good day.